All right, we'll wait just a few minutes until everyone starts trickling in. All righty, so we'll go ahead and start. Good afternoon, everyone, and welcome to today's webinar of mental health in the workplace. My name is Kristen. I'm one of the student interns in the mental health section, and I'll be one of the moderators today. We do have two co-sponsors that are joining us, which is the Occupational Health and Safety section and the Injury Control and Emergency Health Services section. We have three featured speakers with us today who will be discussing different facets of mental health in their profession. By the end of our time today, we do hope you gain more knowledge and insight into these topics. So before we get started, I'd like to go over a few housekeeping items for today's webinar. You can expect each speaker to have the floor for about 15 minutes, and we'll conduct a short Q&A at the end of each session. You may send in your questions at any time during the presentation. We'll collect those and address them during the Q&A portion at the end. So without further ado, I would now like to introduce our speakers today. And so the first is Jonathan. He's a principal consultant at AJ Rosen and Associates. He provides occupational safety and industrial hygiene services to labor unions, government agencies, and organizations throughout the U.S. Jonathan works for the National Clearinghouse for Worker Safety and Health Training, National Institutes of Environmental Health Sciences Worker Education and Training Program. In that capacity, he has developed worker and leadership training programs on disaster preparedness and response, resilience, stress, trauma, opioids, and the workplace, and infection prevention and control. Jonathan completed a master's degree in industrial health at the University of Michigan and is a certified industrial hygienist. Okay, so we'll go over to you, Jonathan. You're muted, Jonathan.
I said, thank you. And I want to acknowledge the support of the NIHS Worker Training Program, which operates the National Clearinghouse for Worker Safety and Health Training. And I am a member of both the mental health and the occupational health sections of APHA. So in terms of the workplace, job injuries and stress are definitely factors in the mental health in the workplace, as well as exposure to traumatic events and the intersection of family and personal issues can also spill into the workplace. The Surgeon General put out a very important report in 2022, which indicated 76% of US workers reported at least one symptom of a mental health condition. 84% said that working conditions contributed to these challenges, and 81% said that they will be looking for workplaces that support mental health in the future. As a practitioner who develops training on mental health and psychosocial issues in the workplace for federal agencies, labor unions, and employers, I can tell you that it's few and far between that these programs are available in some of the workplaces that have the highest amounts of stress and trauma. So that's the challenge. How do we get this recognized and and integrated into the workplace? Here's the framework from the Surgeon General's report. Excellent framework. There's also an association between traumatic stress and substance use. You can see the examples on the slide, and the data is saying 45% of the people suffering from PTSD also have a substance use disorder. And so there's an intersection between the struggles around mental health, substance use, alcohol, and suicide. Case and Deaton have written extensively about deaths of despair, and we've seen a drop in life expectancy, although there was a slight uptick in the last year. Factors such as unethical marketing of opioids for chronic pain treatment, poverty, joblessness, housing and food instability, trauma and racism, as well as occupational injury and stress, have all contributed to this dilemma. You can see the trend over the years. This is a construct that we don't have time to go into in any depth, but it tries to get into a roadmap for the evidence basis around deaths of despair. In terms of suicide at work, the 2021 rate was 33% higher than it was 20 years ago. Bureau of Labor Statistics is recognized for underreporting because employers do the reporting, and but in 2022 they recorded 267 deaths on the job from suicide, which was a 13% increase from the previous year. These are deaths that occurred in the workplace. And the previous major increase was in 2008 when the recession hit. So you can see the economic connection. Here's some of the important factors. I mentioned hopelessness, uncertainty, toxic work conditions, bullying, and a lack of control. Here's an overview of suicide at work. And you can see most workplaces are not prepared to prevent or respond to a suicide. And so that is a gap that we need to address. And there's simple training that can be conducted. For example, workers can be trained to listen to a coworker, and that it's okay to ask them, are you thinking of hurting yourself? That type of thing. There's practical things. And then they need to have access to professional treatment and support. That's a critical need. Construction and mining are two of the industries with the highest rates of suicide, as well as overdose fatality. A lot of it has to do with the nature of the work. Often those workers are working in pain. Construction workers have difficulty accessing sick leave, work long hours, there's fatigue, and it's also part of the work culture to use substances, and those are some of the key factors. You can see this study, major study of New Mexico workers' comp. It showed that suicides may be an important, suicides and drug deaths may be important contributors to excess mortality of injured workers. We all know that during the pandemic, we've seen a big increase in symptoms of mental health, and that's certainly been a factor in the workplace, especially for our essential workers, those that remained on the job, people like healthcare workers, transportation workers, agricultural workers, had some of the higher rates. Here's some more data about increased in mental health crisis calls during the pandemic. Stigma is a huge factor that affects the ability of people to come forward when they're struggling with mental health or substance use issues. A lot of the policies in the workplace are punitive. If you test positive for a substance, you're fired or given a last chance agreement. And there's an effort to reform that and develop what we call the recovery ready workplace. And this approach is one that supports people rather than punishing them if they come forward with an issue around mental health or substance use. And that's a major change because we've had for 50 years zero tolerance and treating these problems as a discipline problem rather than one that deserves compassion. My friend Kyle from the Operating Engineers Union came up with the slogan, "It's time to get uncomfortable and talk about substance use, mental health, and suicide." And they have what they call a member assistance program where they're able to get members to get treatment and recovery support, and they have the support of the contractors. The traditional EAP, one of the concerns about that, the worker who is struggling has to approach the EAP. And as you can see from these quotes from these United Association of Plumbers, Steam Fitter, and Welder construction workers, a lot of the issues of stigma and fear of confidentiality are a deterrent to people using an employee assistance program. So the openness is the first step to getting people into treatment and recovery. So a lot of what we need is to work on the workplace culture so that people will feel comfortable coming forward. We've applied a public health strategy to prevention. Primary prevention is preventing the underlying causes, workplace injury, especially ergonomic injuries, sprains and strains are associated with the misuse of prescription opioids or self-medication, workplace stress, understaffing, bullying. Secondary prevention is getting injured workers information so they can seek alternative pain treatment and talk to their providers. NIHS WTP has a fact sheet, which you can get to by Googling National Clearinghouse for Worker Safety and Health Training. And tertiary prevention is the whole area of reforming punitive drug, alcohol, and workplace mental health policies to becoming supportive ones. Here's a graphic that I just reviewed. So here's some of the risk factors. Presenteeism, that's when people come to work when they shouldn't be there. A loved one dies, or you're going through a trauma, and you're at work, but your mind is on that problem. If you're in a safety-sensitive job where you could hurt yourself or others, you really shouldn't be at work when you can't concentrate. However, the lack of access to sick leave or other workplace policy might require that you come to work. The NIHS Worker Training Program has developed training resources. Here's the link. We're making a PDF of these slides available to you so that you'll have access to these websites. Here's some of the protective factors in the workplace. And I mentioned about member assistance programs. The labor unions have an organization called Labor Assistance Professionals that certify the people leading these programs. They train member assistance people who are on the job to listen and refer. And having that, one of the advantages there is that they can go up to a coworker and and they're trusted, and they're on the job, and they're peers. They understand the industry and the culture. The National Institute for Occupational Safety and Health has a website on the workplace supported recovery. It's the same as Recovery Ready Workplace. And here's the definition and some of the key elements. There's a lot of benefits to the employer if they're transitioning to this. The National Safety Council has developed resources, as well as the U.S. Department of Labor. Here's some of the cost savings involved in hiring people in recovery or helping existing workers get into treatment and recovery rather than firing them. And in conclusion, if we create safe and caring cultures where people can ask for help for themselves and others, we can create a more productive workplace, and we can proactively address mental health and address the behaviors that are underlying some of the problematic conditions in the work environment that can lead to mental health or substance use problems. So physical and emotional pain should both be considered, and the mentorship and training of workplace leaders, managers, supervisors, union officials, and trainers is really key, and also access to care and parity of care. And here's more information. You can also use your phone to get to these links. And I want to acknowledge the support of the folks on this slide, and thank you for your attention.
Okay, thank you so much, Jonathan, for your insight. And now we'll turn it over to Jenn. Jenn is a doctoral candidate at the Oregon Health and Science University School of Public Health and a member of the OHSU Gun Violence as a Public Health Issue Initiative Advisory Committee. She previously worked as a civilian manager in law enforcement, where she became interested in the relationship between officer mental health and community health. For her dissertation, she is performing a trauma-informed analysis of police department mental health wellness policies. Over to you, Jenn.
Thank you so much, Kristen, and thank you, Jonathan, for teeing up a great discussion on this topic. So today I want to talk to you about the mental health wellness of law enforcement officers in the U.S. But before we get started, I want to acknowledge the people who have taken care of our land since time immemorial. Because I am at a joint school of public health, there's 2 universities and multiple land acknowledgement statements. So rather than read both, I just want to thank the Multnomah, the Cathlamet, the Clackamas, the Tumwater, the Chinookian, the Tualatin Kalapuya, the Molalla, and the Wasco people, as well as any others who have taken care of the land that I live and learn on, and continue to take care of the land and all of us. I think it's also important to acknowledge my own positionality within the work I do. So personally, I am someone who is both Native and white, and I grew up in a family that was not particularly friendly to law enforcement. Professionally, I actually spent 8 years as a civilian manager working in local law enforcement, roughly from the time span of when Mike Brown was killed in Ferguson, Missouri, to the conviction of the murderer of George Floyd and the aftermath of that. And then academically, as Kristen mentioned, I am a doctoral candidate in a school of public health. My particular area of interest is health systems and policy. And that means I can sort of be a little bit in the proverbial ivory tower, but I try to make sure that I come down to earth as well. All of these identities and experiences I have shaped how I see the world and interact with it, and it also shapes how others perceive me and the work that I do. So as we move forward to talking about officer mental health, I want to take us back to 2014 when President Obama convened the President's Task Force on 21st Century Policing. And the task force, as part of its final report, identified one of the key 6 pillars to 21st century policing as officer wellness and safety. And the task force said that an officer whose capabilities, judgment, and behavior are adversely affected by poor physical or psychological health not only may be of little use to the community they serve, but also may be a danger to the community and to other officers. And this is a really important issue from a public health perspective because officers experience some pretty meaningful and substantial disparities in mental health disorders when we compare them to the general population of working age adults. So here you see the rates of mental health disorders in both police officers in the darker green on the left of each cluster, as well as general working age adults on the right in the lighter green. And you see that there's some pretty large disparities in rates of alcohol use disorder, depression, both symptoms of PTSD as well as formal diagnoses of PTSD, and suicidal ideation. And there's a variety of reasons why law enforcement officers experience these higher rates of mental health disorders. These include individual characteristics such as their age, their sex and gender, their race and ethnicity, how long they've been working in law enforcement, as well as adverse childhood experiences, which we know continue to affect people across the life course. Jonathan mentioned several occupational risk factors that are associated with poor mental health and substance use in workers generally. This definitely applies to law enforcement as well. Law enforcement are exposed fairly regularly to trauma in their workplace. This can be considered direct or primary trauma, such as when they cause harm to others through the use of force, as well as when they are directly affected by something like being assaulted. Officers can also experience what is variously called indirect or secondary or vicarious trauma. This can include things such as responding to the scene of an active shooter, assisting at a vehicle crash, or perhaps assisting a victim of sex abuse. Additionally, officers are also exposed to occupational stress, and this is non-traumatic stress that is associated with the work they do. And it's generally broken down into 2 categories. The first is operational, which is really that day-to-day work that an officer is performing, such as driving an emergency vehicle in inclement weather. That can be very stressful when you're driving at high speeds in the rain. There's also organizational stress, which is the stress of the bureaucracy within which they work. That incorporates things such as their relationships with supervisors, perceptions of whether they live in a or whether they work in a supportive workplace, as well as things like burdensome policies. Now, law enforcement agencies have adopted a lot of different types of interventions to support the mental health of officers. And many police departments and sheriff's offices have created what I like to think of as essentially very small mental healthcare systems. And these systems include a variety of interventions, one of which is trainings, such as you can see we often have things like resilience training or mindfulness training. There's also interventions such as critical incident stress debriefing and management, which is designed to help work units after they have been exposed to a serious trauma, such as an officer-involved shooting or another fatality. And then we have other interventions such as peer support, which is very similar to the peer support model we see in substance use and serious mental illness. And there's also the use of chaplains, mental health clinicians, which may be directly employed by law enforcement agencies, or there may be referrals made to those clinicians, likewise for substance use treatment. Some law enforcement agencies have their own suicide prevention programs, and then some agencies also have what may be called wellness time or fitness time that's designed to support not just the physical health of law enforcement officers, but their mental health. But these interventions are not These interventions are primarily targeted at the individual level and a little bit at the work unit. And because of that, we can see that they're not necessarily as effective as we would like them to be. We saw that in those high rates of mental health disorders among police officers. So if we adopt a public health perspective, trying to reduce those rates of mental health disorders, we want to look beyond the individual level. We want to look at the relationships that officers have amongst their peers, amongst their supervisors. We also want to look at the community level, which in this case includes their workplace, the police department or sheriff's office they work for, but it also includes the city or county that they serve. And then we also want to look at the societal level, which includes sort of the political milieu that people are operating in, as well as their broader geographic area and state or national policies affecting their work. So I want to talk a little bit about research I'm doing to try to fill in this gap just a tiny bit. And before I do that, I want to talk about challenges in performing public health research, or really any research with police. There's 3 key challenges that have been identified in the literature, and they are partnerships with law enforcement agencies, collecting data, and establishing evidence of causation. It can be difficult to create partnerships with law enforcement agencies. They may be very skeptical of partnering with academics because they may be concerned that they will be portrayed in a very negative light. So it's important when trying to establish partnerships with law enforcement agencies to be very upfront about the work that you will be doing in your research and how you anticipate sharing results, whatever those results may be. Another key challenge with law enforcement is getting access to data. While law enforcement agencies collect a tremendous amount of data, a lot of it is protected by a whole slew of local, state, and federal regulations that makes it difficult to get access to those data. Also, the data, because they are administrative data, may not be what researchers think of as particularly clean data. And then finally, it can be difficult to establish what we think of as really good, strong evidence of causation in police research. A lot of this comes down to it can be very difficult to do what you might think of as the gold standard, such as a randomized control trial, or to account for spillover effects when implementing interventions. Now, my own research is to perform a trauma-informed analysis of mental health wellness policies that are being adopted by law enforcement agencies across the country. And I'm doing this research in 3 phases. So phase 1 that you see at the top in blue is now complete, and those results I'll be showing you momentarily. For this phase, I took a stratified random sample of police departments across the country. I looked at their websites to see if they had publicly available wellness policies on those websites. And then I analyzed the characteristics of agencies that have those policies. In the second phase, which you can see at the bottom in green, I have taken a purposive sample of law enforcement agencies in a state here in the Pacific Northwest, and I'm currently interviewing law enforcement officers about the mental health wellness programs their agencies have, as well as what mental health wellness policies would look like if they were trauma-informed. This is really important because those policies govern how a law enforcement agency reacts when an officer needs mental health assistance. And then finally, in phase 3, I'm going to bring it all together and perform a trauma-informed analysis based on those officer perspectives of the policies I collected in phase 1. And then I will be creating a typology and looking at what types of agencies adopt what types of policies. So getting into those very early results, my stratified random sample actually looked at the websites of 637 law enforcement agencies from all across the US. They are a variety of municipal or city police departments, county sheriff's offices, as well as tribal police departments. And I grouped them by their size. So small, if they have fewer than 24 officers, medium, if they have 25 to 99, large if they have up to 999 officers, and mega if they employ more than 1,000. And what I found of these 637 agencies that I sampled, at least 205 have some sort of publicly available policy on their website. This could include mental health wellness policies, but also things related to use of force, such as what happens if there's an officer-involved shooting or body-worn cameras. Of my sample, 121 had at least one wellness policy that was available on their website. And when we break down those wellness policies, you can see the various types of policies here. The most common type of policy that agencies had to support the mental health wellness of their officers are actually chaplains policies, followed very closely by clinicians, as well as peer support teams, and critical incident stress debriefing and critical incident stress management. Substance use referrals or treatment, suicide prevention programs, and wellness and fitness time were relatively less common. And in the final phase, what I did is I looked at the types of policies and I used a method called qualitative comparative analysis to determine whether there are particular types of agencies or combinations of factors associated with agencies that are related to adoption of policies. So here you can see 3 different outcomes, whether an agency has at least one wellness policy, as well as the outcomes for clinicians and peer support policies, and the combinations of agency characteristics that are predictive or consistently associated with agencies adopting those policies. So for example, you can see that peer support policies, 85.7% of mega-sized municipal police departments in the western region of the US have a peer support policy in my sample, but this actually only covers 7.9% of the adopted peer policies. There is a large amount of heterogeneity in my sample, so there's not a lot of consistency in the predictors of which agencies or which types of agencies have actually adopted these policies. And with that, I would like to thank you for your interest and your attention. Kristen has gone ahead and will be posting a link to my slides in the chat if you would like to download them, including references and explanations of the images in my presentation. Thank you so much.
All righty, thank you. And now we're going to go ahead and hand it over to Dr. Pamela Valera. She is an assistant professor in the Department of Urban Global Public Health at the Rutgers School of Public Health. Her research focuses on the social drivers of health inequities and marginalized groups, including people who use drugs, people living with HIV, and those at risk for HIV, and those involved in the criminal justice system, and the mechanisms for implementing mental health first aid for correctional professionals. She is also committed to addressing health inequity, that's further demonstrated by her co-founding of the Community Health Justice Lab at the Rutgers School of Public Health. This innovative platform is dedicated to tackling inequity among medically underserved and hidden populations, inspiring change and progress in the field. And now I'll hand it over to you, Pamela.
Thank you. Thank you, everyone, for being here today and for Jonathan and Jen's excellent presentations. And the title of my presentation is The Impact of Working in a Correctional Setting, Correctional Police Officers Perceive Mental Health and Suicide Risk. Just a second. Okay, our team does not have any relevant financial relationships with any commercial interests. Just wanted to note that as our disclosure. And so as we think about correctional police officers, we want to give you some background about who they are. So correctional police officers encounter a lot of workplace hazards for managing and controlling incarcerated individuals, and this includes really dealing with constant vigilance inside the facility. There are a lot of fiscal risks that the correctional police officers endure, and high levels of violence, overcrowding inside the facility, exposure to traumatic events, occupational hazards such as physical injury, infectious diseases, emotional exhaustion. These are all issues that impact correctional police officers in the workplace. That being said, we know from several studies that correctional police officers also endure emotional challenges, and some studies have noted that 20% of our correctional police officers are unable to find pleasure in anything, and about 30% of our correctional police officers report a sense of hopelessness. This can result in suicide risk-taking behaviors. A 5-year study conducted in Massachusetts in the Department of Corrections indicated that 105 per 100,000 correctional police officers are 7 times higher than the national suicide rate. And so we wanted to just report on our study phases of the study. The study was conducted in 3 phases. Phase 1, we convened a correctional police officer committee involving 8 senior level officials. They participated in 2 focus groups, and these committee members shared their experiences and knowledge regarding mental health and wellness programs in the correctional settings. And some of the steering committee members held, senior level positions, such as the director of the police academy, a former commissioner, retired correctional police officers, former director of the urban county jail, and we also ensured that we had a correctional psychiatrist who works closely with correctional police officers. Phase 2, we conducted a survey to elicit demographic and characteristics associated with exposures to stressful situations and mental health impacts among correctional police officers. And this survey, our ideal study sample, we wanted to recruit 200 correctional officers of different ranks who work in either a jail or prison in the state of New Jersey. And in phase 3, we gathered the steering committee's perspectives and solutions to address mental health among the correctional police officers. And we wanted to utilize the perspectives of this committee to identify key solutions. So in phase 1 of our study, we invited the senior level folks to identify barriers. Phase 2, we looked at understanding their correctional officers' stressful situations. And then phase 3, we gathered the steering committee again to identify potential solutions. So the task force group meetings, we're calling our meetings with our correctional steering committee task force meetings. This insisted of 90-minute focus groups, was conducted via Zoom, and we wanted to understand some important topics. These include managing mental health challenges in the facility, stressful experiences working in the correctional setting, the impact of COVID-19, interventions to reduce suicide and barriers, mental wellness, fire ownership, and homicide. And participants received a $150 gift card for their participation. And in our study, we found that we had a 78% response rate for our cross-sectional survey. A total of 157 participants completed our survey. And here's the a snapshot of our survey items. So our survey items included, understanding officers' physical health. We wanted to look at in suicide behaviors, intent, ideation. We also wanted to understand more about their substance use, sleep behaviors, diet, and whether there are any mental health well-being in the workplace. In our qualitative analysis plan, we use a narrative analysis to identify the themes in participants' lived experience. This narrative focused on storytelling to better understand the context in which shared stories are situated. We also recorded our focus group meetings with our task force members, and we transcribed these verbatim, and also wanted to sort of monitor people's nonverbal cues. And then we did line by line coding to make meaning of people's stories. And 2 independent coders transcribed to accomplish intercoder reliability. In our quantitative analytical plan, the data was exported from Qualtrics, and we use SPSS and SAS to analyze our data. The analysis included, some descriptive statistics and understanding the scales or indices, psychometric properties. And we use binary linear regression to explore the associations between race, gender, and burnout, and psychological distress and suicide behaviors. Here's a brief sort of snapshot of our social demographic characteristics of our participants. So we just wanted to give you a little bit of more background about our recruitment procedures. So we used social media, personal networks, and really the help of task force members to recruit our potential participants. And all participants received a $25 Amazon gift card for their participation. And when we look at our data, we see that 59% of our sample were predominantly African-American or Black individuals, 41% are white, and when we look at the Hispanic Latino, we noticed that 20% identified as Hispanic Latino. And the survey also included females in our participation. 63% not 63%, 36% identified as a female. And this is not surprising given that, working in a correctional setting is a male-dominated career. We were also fortunate to learn from seasoned and correctional police officers. So 39% of our respondents worked over 18 years in a prison or jail capacity. And in terms of work size, 69% of the respondents work in a jail facility. So, and then this studies, this displays slight disparity in sleep, but not by much. So we noticed there is some, very minor discrepancies between sleep health among male and female correctional police officers, and also as it relates to burnout. Recognizing that we do need to really understand, wellness in our population. So, we're seeing that when females or women are experiencing higher levels of burnout, personal burnout, and working at a correctional setting. And in terms of substance use in the past 3 months, about 20% of our correctional police officers are using cannabis. 20% report tobacco smoking. 70% of our sample reported using sleeping pills to sleep, and about 5% reported using prescription stimulants. These findings underscore the importance of raising awareness of using substances within this correctional police officer community. We also wanted to look at gun ownership trends as and what we found was, close to 70% of our sample personally own a gun in their home. 48% of our correctional police officers have guns that are loaded in their home, and majority of correctional police officers report owning a gun for personal safety and protection, and about 58% store their firearms at home in a gun safe. The next couple of slides, I just wanted to include a disclaimer that we will be discussing suicide that may be distressing to some individuals. So in terms of suicidal behavioral trends, our survey brought to light a concerning issue: the presence of suicidal behavior experiences among correctional police officers. The data revealed alarming statistics as it relates to suicidal thoughts. So in terms of frequency of suicidal thoughts, we found that 14% of our correctional police officers reported experiencing thoughts of suicide at some point in their career. The data also indicated that significant number of correctional police officers have experienced thoughts of taking their own lives within the past year. So about 10% of our sample have noted that. And when in terms of thoughts of killing themselves, it's really important to note that at least 10% of our sample have indicated such. Now, in terms of suicidal thoughts, our survey indicates that at least 6% of our sample mentioned to someone that they might kill themselves. And then in terms of expressing suicidal intent, about 1% of our sample said they will kill themselves. And I want to highlight the importance of really bringing wellness into these settings. So correctional administrators ought to recognize the urgency of the situation. We must fully commit to providing immediate and urgent assistance to our first responders. So correctional police officers are considered first responders. They're the first to respond to any issues that impact the lives of correctional staff or incarcerated people. And we also need to address the needs of correctional police officers when it comes to their mental health and those who have expressed suicidal intent. When we met with our task force members, their qualitative data is quite similar to the quantitative data that we identified. So this included lack of preparation. The senior level administrators felt that correctional police officers are not prepared to deal with incarcerated people. They have insufficient tools for managing incarcerated people with severe mental illness. That said, they've also said that the setting becomes a very hostile environment where people are overly stressed. There is difficulty of working longer hours to support other team members. And with that, police officers have noticed or experiencing losing friends and colleagues by suicide, which is often sudden and unexpected. And most importantly, there's lack of support from family, administration, and the impact and the emotional and psychological toll of working in the correctional setting. And this impacts their ability to even express the need to ask for help. Some of the quotes that I wanted to share with you from our senior level administrative group members, a couple of them have noted, and they were very difficult to deal with. Tools that we were given to handle these, people were very limited. It becomes difficult every day, the longer you work inside that building. I work with many people closely and they're not here anymore to talk, to tell their side of the story. It's a silent killer. There's no release. And like I said before, I said you go home and nobody at home understands. Historically, administration told correctional officers to stay behind the wall, keep quiet, and just be guards. So in addition to inherent danger that used to be 20 to 30 years ago, now you're worried about the court of public opinion before you even get condemned for anything. Some of the potential solutions that the steering committee, the task force members noted was to allow correctional police officers to store their weapon in their facility, enhance hiring requirements, more personal screenings, encourage officers to seek outside mental health therapy and counseling, and develop a multidisciplinary collaboration to really understand the mental health and wellness of our correctional police officer workforce. That includes bringing to the table Department of Corrections, administration, county officials, unions, and also correctional police officers. And some quotes that I wanted to share with you all. So, and I would say a good 60 to 70% of the people I see in my private practice are law enforcement personnel. And as a public employee, they have great insurance typically and can afford seeking a mental health professional. One thing I would be curious about is the ability to secure weapons at the facility. Some facilities allow an officer to turn their weapons in. I think there should be more time and research and empirical attention to what are the characteristics of individuals that really do well as officers versus those that really, it's just not a good fit. And I truly believe that the standard psychological measures that are typically used for pre-employment screening don't really capture that. And in summary, mental health and wellness in the criminal justice system is critical to the safety of all correctional professionals and incarcerated populations. Potential solutions are urgently needed. And we just wanted to share a slide on mental health support. So there's Cop to Cop, and of course, 98 Suicide and Crisis Lifeline. And we want to acknowledge our team, our senior level criminal justice administration team, the policymakers, the officers, and our research team, Valera Ortiz, our criminal justice consultant, Deanna Potter, data analyst, Dr. Saki, quantitative methodologist, Asia, our research assistant, and Kendra, our focus group facilitator. And this project was funded by the New Jersey Gun Violence Research Center at Rutgers University. And that's all I have.
Okay, thank you so much, Dr. Valera. So now is the time where we have our Q&A portion. So hopefully you've had some questions during the presentation. I'll go ahead and turn it over to Sheridan. And if there's any questions, she can answer, and also the presenters.
And if you don't want to, I don't know if you have the capability to turn on your mic, but you can type in the question and answer box and we will answer the questions.
So in the meantime, I do have a question for Jen. And so while we're waiting for questions, I'll go ahead and ask mine. And the question I do have is, so in the public health perspective, along with the intersectionality of mental health, what are some implications in that?
Yeah, thanks for asking that. So I think there's huge implications. We have over 18,000 law enforcement agencies in this country. So that's a lot of law enforcement officers, well over 100,000 working. So it's not a small population. So we can think of that as just being an important population from size perspective. But the other public health implication is obviously police officers are interacting with members of the public. And the way I explain my work to police officers is that I want police officers to be at their best so that they can do their best possible work when interacting with the community. There is some evidence that we have from self-report by police officers that they are more likely to use inappropriate levels of use of force in the public when they are experiencing mental health disorders. We also have evidence that police officers say they may be likely to actually avoid certain interactions with members of the public if they're experiencing the effects of trauma. And that avoidance of interactions can also be a very negative effect on the community. Obviously, inappropriate use of force poses a risk of injury to the people against whom force is used. It also affects other members in the community, though. We've seen effects such as there are decreases in the rates of live births to pregnant people when there's been an officer-involved shooting in their community. We see effects on GPA of students in K through 12 if they just witness someone having force used against them. So this is definitely not just a mental health in the workplace issue, but this is an entire public health issue that affects all of our communities, and supporting officer mental health wellness is supporting all of us.
Awesome. Thank you. Thank you. I do have another question. Well, this is for Jonathan. Jonathan, what are some pathways to substance use recovery? Is there a specific time to recover for that? Or does it differentiate? Does it make a difference between each person? Can you give some more explanation on that?
So one of the biggest problems is access to treatment. And what I've learned from my colleagues in the recovery community, there's different pathways to recovery. Some people will go to an inpatient treatment if they can get access to it. Not all of those programs are created equally. There's horror stories about people flying to Florida for free and then unscrupulous providers trying to get like $25,000 from them. But there are excellent treatment providers. So employers, labor unions, communities really need to vet to find treatment providers that have a good track record and that are appropriate for the folks that are going to them. Some folks are able to get treatment through peer programs. In New York, we have certified peer recovery specialists that go through extensive training. These are people with lived experience. And I think one of the common themes for all of the populations we've been talking about, if you can have peers who've recovered from mental health or substance use that are advocates, that have walked the walk and talked the talk, and they're working side by side, that's a powerful agent for getting people the help that they need, whether it be through a formal treatment program or if they do it through a peer advocacy network. For example, the operating engineers in Connecticut, with their member assistance program, they have meetings every Thursday night in the Union Hall. And they're not only open to the construction workers who are struggling with substance use and mental health, but they're open to family members and non-union construction workers. So that's just one example. The third pathway, some people are able to quit on their own. I was surprised to learn about that, but a construction worker from the plumbers told me he quit on his own. He was addicted to meth. And I asked him what his motivation was, and he told me, my wife told me I had to do it. So most of our employment-based programs and state-based supports require that you go through a state-certified treatment program. That's a problem because that's not the only pathway that people have to recovery. But access to treatment is huge. Even though there's parity requirements under the federal Affordable Care Act and many state laws, many employers are not implementing parity when it comes to mental health and substance use treatment. So that's another huge problem. And the last thing I want to mention is I think we haven't really gotten too much into some of the root causes of a lot of these problems. You talk about the prisons, for example. We had a whole period of mass incarceration of Black and brown people for nonviolent drug offenses. In New York, we called it the Rockefeller drug laws. And Governor Cuomo, Mario, built more prisons than anybody in the history of the state. And so that added to the stress of the system. And now his son, Andrew, shut down a lot of those prisons, and that's good. We don't want to lock up people who are struggling with mental health or, substance use problems. We want to get them into treatment. But the prisons have kind of been the surrogate treatment approach. I've read books that have said there's more people with, mental illness and substance use problems, and HIV, by the way, in the prison system than anywhere else. And, maybe Pamela wants to jump in, or Jenn on this discussion.
It's very true, Jonathan, because one of the major problems that we're having now in I would say both the jails and the prisons, is the fact that these facilities have become the de facto mental health hospital, and the officers are not equipped to really manage that at all. So when they're seeing someone who is suffering from a severe mental illness, they think that they're being defiant, but they could be because they're not taking their medication properly, or the correctional psychiatrists have switched off the medication. There's very little communication between the medical staff and also the officers. So without that, clear communication, the officers are left with very little tools to understand the behaviors and dynamics of the facility. So until we start to prioritize mental health across all populations, that's the only way that things will change. But for now, we have these correctional police officers. When they serve as our first responders. They're in that facility with the incarcerated people 24/7. Sometimes some of them are working second and third shifts. You're looking at 16-hour days, and so when they come home, they also have a family too, and they have children, and they can't really relate to them because they're super exhausted and dealing with the intensity and the stress that's in the workplace.
Thank you both. Thank you.
One other thing I wanted to mention is the changes in our economy are a big factor. We went from 70% industrial and a lot of unions that gave workers a voice, decent wages, paid vacation, the ability to send your kid to college, to now it's 20% industry. And a lot of the jobs that replace those industrial jobs are low wage, low benefits, a lot of bullying. Those are rough environments. So the APHA OHS section published a policy statement on decent work, which I put in the chat box. And I think that's an important factor. And when it comes to the correctional officers, with the shutting down of these facilities, there's a big concern about where am I going to be working in the future. That's also true for coal miners with the effort to eliminate fossil fuels, to deal with global warming. There's a concept called just transition. And the idea there is we should be supporting the transition of workers who are affected by these economic changes, not just with training, but actually getting them employment. That was what was done under the New Deal when FDR was president. And we can still see a lot of the parks talk about the Civilian Conservation Corps. I think we need a renewal of that type.
Mm-hmm.
All right, thank you. Sheridan, do we have any other questions that was in the chat? I think there was one that popped up.
I did not see any questions. I don't
Okay.
have any.
I want to share, I just want to respond to Jen's question. So she asked, what would be the one takeaway message you would want to share with administrators of correctional facilities to support the mental health of officers. And Jen, I have to say, I love your presentation. And I think if I had the opportunity to speak with the administrators, is to really look at their policy on wellness. And I'm sure what you found, in Oregon is probably very similar to what we have here in New Jersey, which is abysmal. And really take into account that we need to include mental wellness in these policies. And that could be, very simple as if you've experienced distress, could you debrief with your supervisor? Could you speak with the mental health counselor on site on duty, just so that you're not holding on to that, that stress, that anxiety, because it is a very stress provoking environment. But and the other thing I would want the administrators to do is spend the day in the facility in different shifts, first, second, third shift, and you'll probably, if you spend a day there in those different shifts, you'll get to understand the lives of the people that you supervise, and that perhaps you can understand and be more empathetic to, the plight of our correctional officers, because at this point, administrators are so far removed from this system, and they're really looking at the bottom line. And I think we have to be more trauma informed. I guess, Jen, that's a great sort of segue to, the future, because we really need to be trauma informed across the board and support the mental health of, the officers, but also the staff that work there too.
That was really great.
Yes, very insightful. Thank you, everyone. Did we have any other last minute questions? Alrighty. Well, I want to thank everyone for attending today's webinar. If you do have any other questions, please contact Jonathan, Jenn, or Pamela. I put their emails here. And on behalf of the APHA Mental Health section and our presenters, along with our co-sponsors, thank you for joining us today, and have a great rest of your day.
There was one question popped up. Will Jonathan and Dr. Valera's presentations be shareable? Can they be shared?
So I put, let's see.
They're both posted in the chat box.
I put Jenn's slides, and I think, Jonathan, your slides, do you have a link to the slides? Because I can go ahead and put that there. Because I think
I don't have a link. I put the PDF.
Okay.
The PDF.
Sure.
Do you have a way of sharing that?
Here,
Kristen?
I can put it. Oh, actually, I can't send a message to everyone. Kristen, could you download it to your computer and then put it to everyone?
Sure.
Okay.
Yes.
And then.
And also Dr. Valera.
Yeah. Did you?
Yes, I'll send you my slides and you can distribute it.
Okay, so the first presentation, we're just waiting on that. And also Dr. Valera's, but Jenn's slides are in the chat for everyone. Alrighty. There's a way to send like a link of it. That would be preferable. I tried to upload. Okay. So she'll send hers after. Okay.
Sorry, I was here to answer questions, but it won't let me put everyone. I can only answer y'all's questions. Oops.
Okay, so Dr. Valera will send hers after the presentation. Okay, so yeah, it will be best to ask everyone here to just email them if you want any copies, so we don't have any confusion or anything like that in the chat. So if you do have questions and want the PowerPoint slides or the link to it, here are their emails. You can just email them and they'll send you these slides. And Sheridan, I believe someone raised their hand. They may have a question.
I'm not, did somebody raise their hand?
Yes.
Sarah?
Okay. Sarah, go ahead.
It says your mic is muted, Sarah.
I apologize. It was accidental. I was trying to click in the Q&A quickly. I was the one just I'm the pest who wanted to have everybody's presentations. I
Yes.
apologize.
Did you get their email down though, Sarah?
Yeah.
Okay.
Thank you.
Yes, yes.
Great. Thank you.
And I happen to know Sarah. She works for the American Federation of Teachers, which has got a tremendous initiative around mental health and stress in the workplace happening.
Teachers need it right now. Hey, good job, Sarah.
And Mitch Rosen says hello, Pam.
How are you? Hope you're great.
Do you have any other questions or anything before we end today?
So are we finished?
I think we are.
All righty. So thank you
Great
again.
job. Good
Joining.
meeting you all.
Yes, thank you so
All
much.
right. Bye, everyone.
Recording.